See you then. Perfect.
Great. Well, I'm Sarah Buchanan. I'm the Director of Federal Government Relations and Health Policy with the Psoriasis Foundation. We are really looking forward to Capitol Hill Day this year. So we'll start with the next slide, please. This training is for all of our virtual attendees, but we've also invited in-person attendees to join as well, and we will email a recording as well as the slides to all of our Capitol Hill Day participants. So the purpose of this training is really to go over our legislative ask for Capitol Hill Day, and then we'll also have a few reminders on what our process looks like. Next slide, please. So if you've done Capitol Hill Day with us for the last few years, you know that we've been doing it virtually. We are really excited to be back in person for part of our virtual Hill Day. We'll also have a virtual component. So part of our Capitol Hill Day, we'll also have a virtual component as well. Next slide, please. So our in-person Capitol Hill Day will be on March 8th and 9th, with our legislative meetings taking place on the 9th. And then our virtual Capitol Hill Day will be a week later on March 14th. Next slide. We do have several trainings taking place ahead of time, particularly for our virtual attendees. So right now we're at this first training, the issues virtual training. This is open to both in-person and virtual attendees, and we'll send out a recording. Next week on the 27th, we're going to have a training on how to do a legislative meeting and how to strategize with your team for legislative meetings. This training is required for all virtual attendees because we will pair you with your teammates and give you some time to start meeting each other and strategizing, and then also trading each other's information so you can continue to do that strategy work if your team wants to. So it's required for virtual attendees. In-person participants can also join if you'd like, and we'll just put you in with some of the other in-person participants that want to attend that training as well. For our in-person Capitol training, we'll be doing in-person training events the day before and for breakfast. So in the afternoon on March 8th, we'll have training before heading to Capitol Hill for our reception, and then we'll also have a breakfast event as well, just to go over the key points and let teams gel before heading to Capitol Hill for their meetings. Next slide. We do have a webpage for you, psoriasis.org/Capitol Hill Day volunteer, with dashes in between each of those last words. I highly recommend checking out this webpage. It has a lot of really great resources, and we'll continue to add more resources as we get closer to Capitol Hill Day. One thing we did make sure to have ahead of this webinar available for you are our backgrounders for you all for each of our 3 issues. So those are just participant-facing backgrounders. I wouldn't share them with Capitol staff. They're really just for you and your information to help you prepare for Capitol Hill Day. Next slide. Right, so without further ado, we'll dive into the presentation. Go ahead, next slide. So I think the first thing to note that's really going to frame all of our legislative asks this year is that the 118th Congress just started, so it's a new 2-year session, started in January. What that means is that all of the bills that we've been working on that haven't passed yet are in the process of getting reintroduced, and there will be new bill numbers. And that also means that all of the supporters, including your representatives and senators that you worked hard with to co-sponsor those bills in past years, we just have to go back to them during this Capitol Hill Day and ask them to hop back on again as co-sponsors. Since it's a new Congress, new bills, new bill numbers, we need to just get all the past supporters back on the bills, in addition to continuing our work to recruit new co-sponsors. Next slide. So we have 3 issues we're focusing on Capitol Hill Day, and Will, Lucy, and I will present on each of these issues. Those 3 issues are: 1, we want Congress to provide $6 million for the CDC chronic disease education program and include report language on psoriatic disease in fiscal year 2024. That's a lot of words. Don't worry, you don't have to memorize this right now. We're about to dive into this. The second topic is we want legislators to co-sponsor the Safe Step Act to reform step therapy and employer plans. I think many of you are returning participants, and this should sound familiar, and we'll cover this topic. And our third topic is we want legislators to co-sponsor HR 830, the Help Copays Act, which would ban copay accumulators, and Lucy will cover this topic. And you'll note we do have the bill number for the Help Copays Act because it was recently reintroduced. And it's a different bill number from last year. And by the time of our Capitol Hill Day, we expect to have bill numbers for the Safe Step Act as well. Next slide. So I'm going to cover our first ask for you all, and that's appropriations. Next slide. So what is appropriations? Congress has the power of the purse, and Congress determines how much government agencies can spend every year. This process is called appropriations. During the appropriations process, communities like us can submit requests to members of Congress. And with our Capitol Hill Day so early in the year, this is the stage where we're at right now, where we're hoping that you can help us ask legislators to include our requests in their submissions to the Appropriations Committee. So again, appropriations is the process by which Congress funds the government, and we're pretty early in the process with our Capitol Hill Day happening in March. So we're hoping to work with you all to ask your legislators to support appropriations for psoriatic disease. Next slide. So this year, as I just said, the NPF is asking Congress to include in fiscal year 2024, $6 million for the CDC Chronic Disease Education Awareness Program, as well as report language supporting psoriatic disease public health activities. And I'll speak to each of these topics in my presentation. Next slide. Part of our mission at NPF is to improve the quality of life of patients. So that includes making sure that trying to improve our system so that patients can reach a diagnosis faster and then also reach remission faster. So we've been working on this for a long time. In 2013, NPF had been working with the CDC for a couple of years, and CDC finally published a psoriatic disease public health agenda. And then finally in 2020, while private entities like NPF, started work on the agenda, the government really didn't do much on the psoriatic disease public health agenda until 2020, when Congress created the CDC Chronic Disease Education and Awareness Program. We were really excited, and I think because of our past work with CDC, really well positioned to apply for a grant through that program to continue the public health activities that were identified in the agenda and that would complement the work we've been doing since 2013. Next slide. So this is what we're currently working on. So one thing we've noticed is that despite treatment advancements, many patients have not reached remission. We've been working to fix that by the following program activities. So our first grant with CDC, we updated the current data we have about psoriatic disease. So again, there's that 7-year gap between the public health agenda and the 2020 program. So some of this needed to be dusted off. We developed new survey tools to fill in the gaps of our data. We began educating the public about psoriatic disease and its co-occurring conditions. And we began educating providers and public health officials about psoriatic disease and its co-occurring conditions, as well as improving diagnosis, particularly among people of color. So an example of our work is on the next slide, where we created this webpage. This is actually a patient-facing or family-facing webpage that can describe how psoriatic disease presents in people of color and
look at that baby.
And helps people just learn more about the condition and how they can find additional support, advice, and stories related to them. Next slide. This work is winding down with the CDC. It was a 3-year initiative, and we're hoping that the CDC will continue to invest in psoriatic disease activities in order to improve the quality of life of those living with psoriatic disease. So what we're working on is working with Congress to encourage CDC to continue these activities through their appropriations process. On the House side, we do expect that Representatives Joyce and Debbie Wasserman Schultz will circulate a congressional sign-on letter where they're going to ask their fellow representatives to join the sign-on letter to the Appropriations Committee with that $6 million ask for the CDC Chronic Disease Education Awareness Program, as well as supportive report language. On the Senate side, there's less senators than House representatives, so you don't see those letters quite as often, although they do happen. This year, our strategy is really just to focus on engaging Senate offices individually to support that ask with the Senate Appropriations Committee. Next slide. You may be wondering what I'm saying when I'm saying report language. I know I mentioned it many times, and it's just non-binding added detail that Congress includes in an accompanying report to the bills that shares with the agency how Congress would like the agency to direct its activities. So this is the report language we're circulating with Congress this year. It will be in your materials. You don't have to have this memorized or read it, but it basically says what I've just gone through, that, despite treatment advances, many patients still have trouble getting diagnosed or finding a treatment plan that works for them. There's some new opportunities just given some of the progress we've been able to make over the past few years. So we want CDC to build upon and expand those activities on psoriatic disease. Next slide. So our key messages are, again, despite treatment advances, many with psoriatic disease have not reached remission. CDC has begun supporting psoriatic disease public health activities through the Chronic Disease Education and Awareness Program, which is great. But in order to make a lasting impact, CDC should continue these public health activities. And so next slide. Our asks for Congress are, I like to frame our legislative asks in yes or no questions. So will the representative or the senator include $6 million for the CDC Chronic Disease Education Awareness Program, as well as report language in their appropriations requests? And then for House offices, you can also flag that there is a sign-on letter you can join. So when you meet with legislative offices, this ask is going to be in your talking points. So you don't have to have this memorized. You can read it right off the talking points. And B, you'll have a copy of the sign-on letter that you can give to the staffer on the House side and tell them we'd like them to sign on to this letter. So that's the end of my presentation on this first ask related to funding for the CDC Chronic Disease Education Awareness Program, as well as supportive report language. I'll pause here and would welcome any questions you have at this point.
Can I make a comment rather than a question?
Sure.
We might want to add something to the background that focuses on the fact that about 30 to 40% of people who have psoriasis are undiagnosed and untreated. Because this is an education program, I think that has some impact.
Great. Thank you.
You also said at one point that many people have not been successful with their treatment. Many is a very vague term. Can we have something that's more specific?
Yeah, so I do have a survey that NPF issued to our community. And initially I was quoting from that survey, but then our public health researchers switched it to many. So, I mean, I can go back and ask them if there's a more specific data point there.
I don't think many works very well.
Great, thank you. Great, all right, well, I will pass it on to Lucy.
Thanks, Sarah. Sorry, I am recovering from COVID, and so if my voice is scratchy, I apologize. I'm going to be covering our second ask, which is to co-sponsor the Safe Step Act. So if you have been an advocate for us with us for a while, you may be familiar with our step therapy asks. Step therapy is an insurance protocol that requires that patients try and fail treatments as per the insurance company before they get the coverage of their treatment that was actually provided for, that was actually prescribed for them by their provider. In fact, a 2020 NPF survey found that 70% of people with psoriatic disease who take a biologic have been subjected to step therapy. So far, on the state level, 36 states in Puerto Rico have passed legislation that reform such policy. So what we are advocating for in DC is a federal level of these protections. So you're not going to be expected to memorize all this information, but we wanted it here to be available. Essentially, what we are asking for is not to ban step therapy or the use of it, but rather to create an exceptions process and to establish common sense guardrails around step therapy. And that includes 5 steps to an exception process and also a timeline to review the process. Next slide, please. Thank you. So you may get asked during your meetings why we need a federal bill if states have already passed step therapy protections already. And the answer to that is that the different levels of legislation protect different types of plans. Some folks are on state regulated insurance plans and some folks are on federally regulated plans. So the protections that we have in place in the 36 states that have passed it do not apply to everybody's plan. So that's why we need to advocate on the federal level for folks that have federally regulated plan, which is also known as ERISA plans, which is basically insurance from their employers. Another question that you may be asked is, what is the cost of this bill? Or is there a Congressional Budget Office score? The answer to that is, while it hasn't been scored by the Congressional Budget Office yet, the states that have already passed similar legislation have shown that it has not resulted in any increases to premiums. So key takeaway messages from this are that step therapy can cause delays to access for critical treatments. And then that can lead to unnecessary hospitalizations and irreversible disease progress. As well as we have had success in 36 states. And that's important to bring up to show that this type of legislation works and it doesn't create massive amounts of extra spending. And the last thing to remember is that we are not asking to ban step therapy. We are just asking to create guardrails and an exceptions process. So in total, the ask is, will this senator / representative co-sponsor the Safe Step Act? And if you've advocated with us before, you have already asked folks for this before, and some of them have supported this in the past. But as Sarah has said, we are going into a new congressional session and we have to start from the beginning. And we also are encouraging a hearing or a markup on this act in the Education and Workforce and Health committees. So those are the 2 main things that you will be asking for in your meetings. And that concludes my portion of the presentation, and we can take questions now if anybody has any.
A quick question. When we're assigned which senator or congressman's office we're attending, will we know how they voted previously, if they did vote previously?
Yes, we will be putting together spreadsheets that will show who has supported in the past and also who is on which committee. That can also be helpful as well.
Thank you.
I should just interject a comment. I'm from Iowa. Congressman Miller Meeks is from Iowa. She was the person who launched the bill, the Safe Step Act. And in the post-election comments, she said her only priority she listed in the Iowa papers was that she was interested in basically reintroducing the Safe Step Act. I worked really, really hard to get in touch with Congressman Feenstra, and I had a personal conversation with him and one of the people from his office, and they all talked like they were going to co-sponsor, but I never saw his name show up, on the list of co-sponsors. But at least Miller Meeks sounds like she's wanting to reintroduce the act. So just a comment.
That's good to know. And it's definitely something that we have to continually ask for. Especially when folks are working on so many bills. It's important to, continue asking until we have that secured support. Is there any other questions? If not, I'm going to pass it over to Will to cover our third ask.
I will take that as a no. All right, thank you, Lucy. So our third ask is we are asking Congress to co-sponsor HR 830 or the Health Copays Act. And again, for those of us on the call who have been advocating with NPF for a while, this isn't a totally new request. This bill was first introduced in the last Congress, the 117th, and we saw some encouraging progress on it. But this year, we want to really build on that momentum and continue to bring this important bill, which would address copay accumulators, another form of insurance utilization management that really affects this community. So that leads us naturally to the next slide. What are copay accumulators? I apologize in advance. There's no simple way to explain this issue. It is inside baseball. It is wonky. I know that. I will do my best to render this into something digestible, but if you have questions, drop them in the chat, or like Lucy and like Sarah, I'd be happy to tackle some questions at the end. So copay accumulators are a utilization management program that insurers impose to collect copay assistance without counting it towards a patient's cost-sharing obligations. So what this looks like in practice is that with the proliferation of expensive drugs and even inexpensive drugs, frankly, in the scale that manufacturers use, but still expensive for the average American's pocketbook, because so many people are having difficulty affording these drugs on their plans, there exist patient assistance programs, copay assistance programs that offer financial assistance so that insurance plan users can access these medications. And so these programs offer cash that is accepted on the patient's behalf, and in an ideal world would be counted towards that patient's cost-sharing obligations in their insurance. What the copay accumulator does is it empowers the insurer to take that money. So they're not going to say, no, we couldn't possibly, right? They are very happy to take the cash. But then once it runs out, they treat it as if that was never even paid on behalf of the patient. So you, the plan user, are still on the hook for thousands of dollars, whatever it takes to reach your deductible and then your out-of-pocket maximum, as if none of that money had been paid. Again, these programs are problematic because the same survey that Lucy mentioned earlier when talking about step therapy also showed that around 70% of people with psoriatic disease who take a biologic reported that they could not afford that medication without copay assistance. So as many people on the call know, and I don't have to tell you, this is not some marginal program that only a few people in the community are taking advantage of. This is a crucial piece of the infrastructure that supports access to care in this community, and really threatening its validity in the eyes of insurers jeopardizes our access to care. I see there's a message in the chat. Can't read now, but I will get to it at the end. So thank you. So again, I apologize. This is a lot of numbers that I'm throwing up on the screens, but this is a helpful diagram that some of our coalition partners came up with in the past to show how a copay accumulator works. So in each of the lines, you could see how much is paid for each billing cycle by the copay assistance. You can see how much of the deductible in the plan is left, and you can see how much the patient is paying. And so a plan without a copay accumulator program, the assistance is paying and that deductible is being cut into. The deductible is being reached and the copay assistance is winding down. As it winds down, that limit is met, the patient is taking on more costs, and then eventually they're reaching their out-of-pocket maximum. And from the rest of the way, they are paying zero, or they're paying some flat, co-insurance rate, more likely, but that's not shown in this graph. And so you can see that in total, the copay assistance is paying $7,000, the consumer is paying $1,350. Yeah, Michael, this sort of gets to the point of double dipping, which I agree is absolutely happening here. In total, the insurer is collecting $8,500. Now, a plan with the copay accumulator program, again, all that copay assistance is being paid at the same rate. You're running out of it. The limit is being met. And then all of a sudden, the patient is being billed, $1,600 a month when they may not have even been expecting this, because many plans have poison pill accumulator language in them that isn't being implemented for years. And then all of a sudden the insurer flips a switch and this component of your plan takes effect. And so you may think January, February, March, there's no problem. And then all of a sudden in May, you get this bill for $1,200 to continue using your medication. And so there's sort of two important points here. One is that you're never reaching the out-of-pocket maximum because none of that money that's being paid by the copay assistance is going towards it. The other is that you're hitting these huge bills. I mean, as you can see here, the copay assistance in this example isn't totally covering all the way up to the out-of-pocket maximum. So the patient is still incurring some cost, and that does happen. But it's a more reasonable expense. And even this is frankly a large expense for many people, right? But it's a more reasonable expense than getting these back bills that just take up a huge portion of the plan user's paycheck. So the other point that I believe Michael was making in the chat is that this is sort of a form of double dipping, because the insurer is taking all of that money and then they're turning around and expecting more money from the patient as if none of that had been paid. And one of the things that American insurance law does is it sets out cost sharing limits for how the cost for certain goods and services should be split between the insurer and the patient. And as you can see, the insurer is collecting far more money in an example where they've implemented an accumulator. So this is really a way of maybe avoiding those cost sharing in obligations and essentially double dipping and collecting more than the insurance law might suggest they should be able to. So how do we plan to address this? The good news is there is a federal piece of legislation, the Help Copays Act. So this was introduced by Congressman Donald McEachin from my home state of Virginia in 2021. So like I said, this was the 117th Congress, was the first that we had a federal piece of legislation addressing this issue. We ended that Congress with 62 co-sponsors in the House, which is pretty good for, I mean, as I was explaining it, I hope you saw, this is a pretty complex issue. It affects people, certainly. It's a serious issue, but it's difficult to explain. And that often means that trying to get action to address an issue like that is like pushing a boulder uphill in Congress. So I think it's really encouraging that we got 62 co-sponsors out of the gate and really educated Congress about the importance of this issue. But we want to continue building that momentum and continue bringing more members on board, understanding our community's perspective and appreciating that this is an issue that needs some form of redress. So this year, the bill is being introduced by new lawmakers, which happens with bills, especially when a chamber of Congress flips like the House did this past election. So now the bill is being led up by Representative Buddy Carter and Rep. Nanette Berrigan. So we're really happy that this is being reintroduced. We, like I said, we want to continue building momentum and continue that process of educating lawmakers about it. But we do need to get everyone back on the bill in the 118th Congress. And this is just like what Lucy said, right? You know, over the last Congress, we held a lot of meetings with lawmakers, taught their staff about this issue, convinced them to sign on. None of that carries over by default into the next Congress. And so we might need to go into offices and remind them. Staff may have left, lawmakers may not have this on their radar or on the top of their priority list. And so our job, even if your lawmaker has, you know, sponsored this in the last Congress, the fact that they're not on it already doesn't mean that they've changed their mind. It might just mean that you need to remind them that this is a priority of their constituents and something that we should address. The other thing I'll mention about this bill is that there is no companion bill in the Senate. This was the case last Congress as well. This has really been an issue that has been taken up more by the House. We'd love to see a Senate version of the bill as well, just to build that sort of dual momentum in both chambers. But even if there's currently no bill, we can still start that process of educating lawmakers and urging them to take a closer look at this issue in the Senate as well. So we'll talk about that a bit more when we get to the asks. So what the bill does is it ensures that all copays count by requiring insurers to count all third-party copay assistance towards a patient's deductible or out-of-pocket maximum. So this just clarifies that insurers have to count copay assistance and prevent situations like the one that we saw in the chart earlier, where all that copay assistance is being taken up by the insurer, but none of it is being credited towards the patient. So they're still on the hook for a huge expense once the assistance runs out. The bill does a second thing that we don't need to go into in as much detail. And the second thing it does is it fixes a oversight in the Affordable Care Act, the ACA, called the Essential Health Benefits loophole. And again, this isn't something we need to go into in too much detail, but this is just a loophole that has allowed insurers to overcharge for certain services, which theoretically should have capped prices due to being ACA benefits. That loophole is what allows them to implement accumulators in the first place. And so we want to address the problem at the root rather than just playing whack-a-mole and dealing with this one narrow abuse of the problem without dealing with the underlying loophole as well. So some questions you may hear. One common response we've heard from insurers and those sympathetic to them about accumulators is, well, aren't these necessary because this is really a drug pricing problem? You know, manufacturers are setting these high prices for name brand drugs that have generic alternatives, and then they're passing that cost on to the insurer by suppressing the patient's expense with copay assistance. So you have an expensive name brand drug you're trying to bring to market, you mitigate that expense for the patient by giving some sort of copay assistance, and then the insurer is stuck holding the bag. And insurers will tell you, this is what's happening, and this is why they're implementing accumulators. And our response is that this really isn't the case for psoriatic disease, because this is a condition for which many of the most effective treatments have no generic equivalent, right? We're talking about biologics. At best, there are biosimilars, but even those come at a relatively similar price point. Copay accumulators applied in these situations, right, where there is no generic equivalent, don't force patients towards cheaper alternatives, which is what insurers will say the goal of the plans are. They force patients towards alternatives that do not exist, and in practice, often impose huge costs or force patients to stop treatment altogether. So, and by the way, this is a bit sort of zooming out from our own specific situation, but research on copay assistance has shown that the vast majority of copay assistance is applied in situations like this, high-cost drugs where there is no generic alternative. So you don't even need to go into that. It's just enough to say that in our specific situation, these accumulators, there is no alternative out there that you can direct people towards if they need a biologic, right? And yet we still see these plan designs imposed, and they really just make it more difficult for patients to access the care they need. So another question you may hear is that if the first provision of the bill, the one that clarifies copay assistance must be counted, effectively does away with accumulators by itself, why does this legislation also address the essential health benefits loophole? And again, I sort of preempted my own slide by talking about this earlier, but the answer is that, you know, the essential health benefits loophole was the original oversight that allowed insurers to come up with accumulators in the first place, but accumulators aren't really the only abuse of the system that insurers have discovered and implemented by exploiting the essential health benefits loophole. So we know that there's a sort of variety of these forms of utilization management out there. And rather than addressing them one at a time, only to watch even more come up, we just think that we should address this loophole in the ACA and head all of these forms of utilization management off at the pass, because they really are sort of in violation of the spirit of the law, if not the letter of it, and really sort of exploiting an ambiguity in the wording to overcharge for things that Congress thought should be essential health benefits. So again, I apologize. I know that this has been a complex issue. I appreciate everyone for following along and asking questions, but if you get a question from a lawmaker in your meeting that you don't quite know how to tackle, or really feels like it's diving even deeper in the weeds than we did here, there are just some key messages that you can fall back on. And our first key message here is that many people with psoriatic disease rely on copay assistance to afford the medications they need. and accumulators jeopardize our community's access to crucial treatments. Again, we have that 2020 survey that shows that 70% of the community who we surveyed on biologics reported they needed copay assistance to access that medication. This is not a niche benefit that only a few people are using. This is an important prerequisite to getting people access to the care that they need. The second point I would make is that this piece of legislation would prevent insurers from running from their obligation to pay for essential benefits that really they should already be covering, right? These medications should effectively be coded as an essential health benefit. And the fact that this loophole exists is allowing insurers to impose these accumulators and pass costs on to patients beyond what the law really suggests they should be doing. And then the final point here is that there have been similar patient-friendly copay accumulator, similar patient-friendly copay accumulator reforms, say that 3 times fast, passed in 16 states and Puerto Rico already. So this is not a radical untested idea. It's something that has been taken up to some degree by the states, but we just believe the issue is important enough that we need some sort of federal remedy here. So I will stop talking there and move to the ask. Like I said, we do have a bill and a bill number already in the House. So in your meetings with representatives, you can ask them, will the representative co-sponsor the Health Copays Act or HR 30? And they have co-sponsored already. We also will indicate that to you in their sheet as well. It's only a few of them who have, but if that's the case, certainly thank them as well for their allyship and their commitment to addressing this issue. And then in the Senate, the ask is a bit different because we don't have that bill. And we're really asking senators to introduce a Senate version of the Health Copays Act. I will say off the bat that this is a huge ask we're making. You know, lawmakers choose pieces of legislation that they're going to introduce carefully because agreeing to be a primary sponsor is a big commitment to a piece of legislation. You have to really believe in the cause because you're chiefly implicated in, you know, organizing a constituency, getting other lawmakers on board, doing a bunch of behind the scenes logistics. It's a big ask that we're making. And so, especially if you're meeting with staff, you're going to get a non-committal answer. You're going to get something like, well, this is very interesting. We'll certainly look into it and be in touch if we have questions. And that's normal. No staffer is going to commit to introduce a bill on their boss's behalf without looking into it. So don't feel, you know, despondent or upset if you don't get that commitment. This is a major ask that we're making. But like I said, it's important to get this out there and to try to start building a constituency for this bill on the Senate side as well. So that's the ask, that's the issue. Apologies that I stumbled over my words a bit there but like I said, we do have to wrap this thing up. So I will turn it back over to Sarah to talk about next steps.
Great, thanks. And I did put the link to the volunteer hub in the chat, so hopefully you should be able to easily access it and read through the backgrounders as well. I loved the comment from Wayne about, you know, taking time to do your own individual study. So our next training is at 8 p.m. Eastern time on February 27th. This is required for all virtual participants. Just a reminder, again, because we're going to link you with your teammates and give you some time to practice with each other and practice using the virtual platform that we'll be using. In-person participants are also welcome to attend. So we look forward to seeing you this time next week. Next slide. And I do want to recognize our supporter BMS for helping us put on Capitol Hill Day. And with that said, that's the end of this presentation, and we look forward to seeing you all next week. And feel free to reach out to us offline as well, and we'll be happy to continue these conversations. Thank you.
Thanks, everyone.
Thank you.